The meeting is now recorded. Good morning and thank you for attending our DUR board meeting. A few reminders for our meeting today. If you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute the device via Google Meet. DUR board member, please preserve your question until the end of the presentation or ask in the Google Meet chat. Public comment, if you would like to provide public comment, a COI must be on file. Please send an email to medicaiddpharmacy@utah.gov. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicaiddpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you very much. And for the meeting today, oh, yes, Jen?
Hi, excuse me, Noon. There are 6 other individuals on a different link, including Dr. Brinton, Kumar, and others. We need to wait just a moment, please, to get others on the line here while I transition over to this other link. Could you hold one moment, please? Yes. Apparently, there was another WebEx that I had joined, and coincidentally, there were several other board members on there. Hold on just one moment, please.
Has the link for this meeting been shared in the meeting chat for the other link?
It has. I'm talking to them right now, Brian. Just a moment.
Perfect. Thank you.
Yep. Thank you. Okay, my apologies for that. I happened to log on to another link, and both Kumar and Dr. Britton and Laura Britton are on that call as well. So I need to send them the other link to this meeting. So I'm okay if we want to get started, but there are several board members who are trying to get on from another link.
Okay, thanks, Jen. Let's give them like maybe 1-2 more minutes.
Yeah, I'm sending them the new link here. I apologize, everyone. Okay.
All right, let's continue our meeting. The first item on the agenda is the minute. Do we have a motion for the minute? Oh, Dr. Siegfried?
Yes, under number 2, my last name is misspelled. It should be Siegfried.
Okay, noted. I will make that correction.
Thank you.
Any others comment on the minute, or we have a motion to correct that last name, Dr. Siegfried?
Move to approve as corrected.
Thank you. Do we have a second?
I second.
Thank you. All in favor?
Aye.
Aye.
All those opposed? Okay. All abstaining. So the motion will pass for the minute with the correction. Okay. Next item is the housekeeping. We have a couple of housekeeping items. Jenny, do you want to go ahead?
Thank you, Anu. Good morning, everyone. We have a few housekeeping items we'd like to update you on. A couple have to do with some staffing changes. One piece we'd like to alert you to is that our new medical director for Medicaid has begun in her role. Her name is Dr. Yoon Kim Butterfield. I believe she is on the call today. And she will have direct oversight of the pharmacy team, as well as the medical consultants that work for us here at the Medicaid agency. Dr. Butterfield, are you on the line?
I am. Sorry, my voice is sounding crazy. I have a little bit of a cold. I sound very sultry this morning, or not, or just scary. But yes, I'm super excited to be in this new role and to be a part of this wonderful, really, really hardworking team. So thank you. I'm excited to be here. So thanks, Jen.
Yeah, thank you. So Dr. Kim Butterfield, I just want to give a quick shout out to her commitment to public health. And I'm doing this from memory, Yoon, so if I forget, but Dr. Kim Butterfield is an internal medicine doctor who also has a fellowship in endocrinology and had served in multiple public spaces in her career. She has worked and spent time during the COVID pandemic at San Quentin Prison, working as a physician there. She has committed time to the refugee population, working at a University of Utah clinic, and most recently came from the People's Clinic up in Park City, where she served as the chief medical officer. So we are really excited to have her here with us, and her commitment to public health and specifically the Medicaid population, I know will benefit the work that we do. The next item I'd like to update you on is just change in staffing for Lisa Angelos has stepped down from the pharmacy director role and will serve as one of the pharmacists on the team. So we just wanted to make that announcement. We will be posting a recruitment for the pharmacy director, but we're really grateful for all the work Lisa's done over the last year plus in her role as pharmacy director, and thankful she'll stay on in her role as a pharmacist with us. The last item is more of a work-related item for the pharmacy program that I wanted to share an announcement around an RFP. A couple months ago, I received legislative directive. The department received legislative directive to conduct a study to evaluate the cost of carving out pharmacy from the ACOs to the fee-for-service program. And so we have begun the work of writing the RFP and detailing the requirements to conduct this study. And the RFP should be posted in the next week. The intent of this study is to evaluate if there are other models of pharmacy delivery, not just carving it all out, but looking at other models of delivery that might optimize the administration, but also the costs of the program. So we will be posting that. The goal was to have this study completed before year's end. Those were my updates for now, noon, unless there are other questions. I think that's what I wanted to share this morning.
Thank you, Jen. Any question for Jennifer? Okay, let's move on to the next item. It will be insulin pump from the University of Utah DRC.
Okay, good morning, everyone. Hopefully you can see the slides. Today I will discuss ambulatory insulin pumps with continuous subcutaneous insulin delivery. Over 37 million adults in the US have diabetes, with the majority of cases being type 2 diabetes, followed by type 1 diabetes, and then gestational diabetes. Patients with type 2 diabetes have some degree of insulin deficiency resulting from defective insulin secretion and frequently peripheral insulin resistance. Patients with type 1 diabetes have complete or almost complete insulin deficiency that is caused by immune-mediated damage to the insulin-producing beta cells in the pancreas. Gestational diabetes is characterized by the onset of hyperglycemia diagnosed in the second or third trimester in women who did not have overt diabetes prior to pregnancy, which typically resolves after delivery. Excuse me. Continuous subcutaneous insulin infusion, abbreviated CSII, via an insulin pump, also called insulin pump therapy, is used to imitate the natural secretion of insulin by pancreatic beta cells among patients with insulin-deficient diabetes. It is estimated that at least 350,000 patients with diabetes use CSII, and more than 35,000 patients using CSII have type 2 diabetes. Insulin pump therapy is an alternative to multiple daily injections, or MDI. Insulin pumps are able to administer pre-programmed or adjustable rates of basal insulin and provide manual or automated prandial and/or correctional bolus doses depending on the device. The various insulin pumps infuse insulin either via tubing from the pump to a subcutaneously inserted cannula or needle, or via a patch-like device that attaches directly to the skin. There are a variety of insulin pump delivery systems available on the market, with newer devices typically having more advanced features. This slide lists the reviewed insulin pumps categorized into system types based on their maximal automation capability. Except for the islet bionic pancreas, all pumps can be used as conventional insulin pumps, which have no automation capabilities other than infusing basal insulin at pre-programmed rates. Vigo, Omnipod Dash, and Omnipod Eros are maximally classified as conventional insulin pumps because they do not allow for automatic augmentation of insulin delivery based on continuous glucose monitor or CGM sensor readings. The remaining insulin pumps are able to integrate with the CGM and offer varying degrees of insulin delivery automation. The MiniMed 630G provides the least level of automation, whereas the iLet Bionic Pancreas has the most advanced automation capabilities. The MiniMed 630G and t:slim X2 with Basal IQ technology are both classified as Advanced Sensor Augmented Pumps, or SAPs. The MiniMed 630G has a low glucose suspend capability that automatically interrupts basal insulin delivery when CGM sensor readings drop below a preset low glucose limit. In addition to having a low glucose suspend function, the t:slim X2 with Basal IQ technology also has predictive low glucose suspend that automatically suspends basal insulin delivery if sensor readings are predicted to drop below a preset limit within the next 30 minutes. The Omnipod 5, MiniMed 770G, 7080G, t:slim X2 with Control IQ technology, and the iLet Bionic Pancreas are automated insulin delivery, or AID systems that automatically increase, decrease, or pause the basal insulin infusion rate according to a software algorithm in real-time CGM readings. Advanced AID systems can also deliver automated correctional boluses, and in the case of the iLet Bionic Pancreas, also give automated mealtime boluses with user announcement of a meal. Some AID systems are also usable as advanced SAPs with low glucose suspend and or predictive low glucose suspend. Currently, available AID systems still require some form of user input for prandial boluses and exercise. All of the reviewed conventional insulin pumps and advanced sensor augmented pumps are indicated for patients with diabetes mellitus without specifying a particular type who require insulin therapy. Among the conventional insulin pumps, Vigos should only be used in adults, whereas the Omnipod Dash and Omnipod Eros have no specified age restriction. Conventional insulin pumps are disposable tubeless patches or pods that require frequent replacement after 1 or 3 days of use. Regarding advanced SAPs, MiniMed 630G is approved for patients at least 14 or 16 years of age, depending on which CGM sensor is used. The t:slim pump and Basal IQ technology are both indicated for patients 6 years of age and older. Both the MiniMed 630G and t:slim pump are reusable tubed pumps. All AID systems are indicated for patients with type 1 diabetes. MiniMed 770G and Omnipod 5, when used with automated technology, are approved for the youngest age of at least 2 years, whereas the MiniMed 780G is approved for patients at least 7 years of age. Note that the indication and approved age may differ between the standalone pump and the respective automated technology. This slide provides an overview of the key features that differ between AID systems. Please refer to Table 3 of the report for a more comprehensive list of features. Notably, the Omnipod 5 is the only tubeless AID system. Except for the iLet Bionic Pancreas, AID systems have a minimum and or maximum total daily insulin threshold to safely use the automated technology. The t:slim with Control IQ also has body weight limits. As previously mentioned, each system allows for automatic adjustment of basal insulin delivery based on a target blood glucose range or value. However, only the MiniMed 780G, t:slim with Control IQ, and the iLet Bionic Pancreas allow for automatic corrective bolus doses. The iLet Bionic Pancreas is the only AID system that automates mealtime boluses, but requires the user to notify the system of a meal with qualitative descriptions of carbohydrate intake. Because insulin needs change during exercise and sleep, most AID systems have special modes that allow users to set a temporary higher glucose target if exercising and or a different target glucose during sleep. Besides the t:slim with Control IQ, which reverts to user-programmed insulin delivery settings, all AID systems have a limited automated mode which typically triggers if CGM connection is lost. Notably, the iLet Bionic Pancreas is the only reviewed AID system that is unable to operate in a manual insulin delivery mode, and if automation ceases, the user is required to use an alternative method for insulin delivery. For recommendations on the use of insulin pumps, we reviewed guidelines from the American Diabetes Association, abbreviated ADA, American Association of Clinical Endocrinology, or AACE, the Endocrine Society, or ES, and a 2022 expert consensus statement on the use of AID systems. For specific recommendations among pediatric patients, we also reviewed guidelines from the International Society for Pediatric and Adolescent Diabetes, or ISPAD. In the ISPAD guideline, recommendations are frequently specified for youth with type 1 diabetes. Considering the context of the guideline and that cited evidence is primarily for type 1 diabetes, the extent to which generally stated recommendations apply to other types of diabetes is unclear. Other guidelines have a broader target patient population with respect to diabetes type. Guidelines from the ADA, AACE, ISPAD, and ES prefer AID systems to alternative insulin delivery systems for most adults and children with type 1 diabetes, given the benefits in reducing A1C, improving time and range for CGM readings, and preventing hypoglycemia. Additionally, expert consensus strongly favors offering AID systems to all patients with type 1 diabetes, including children who are at least 7 years of age, adolescents, and adults, and for AID systems to be considered for preschool-age children. As part of the strong recommendation for AID systems for people with type 1 diabetes, AACE also notes that AID systems can be considered for patients with diabetes who have suboptimal glycemic control, hypoglycemia unawareness, significant glycemic variability, or have permissive hyperglycemia in response to hypoglycemia-related fear, but it's unclear to what extent this part of the recommendation applies to people without type 1 diabetes. Based on expert opinion, the ADA recommends offering AID systems to patients with any other type of diabetes requiring insulin therapy, including patients with diabetes-related cystic fibrosis. Similarly, based on low-level evidence, panel experts advise offering appropriate AID systems to patients with type 2 diabetes or other types of diabetes treated with MDI or already on insulin pump therapy. ISPAD strongly recommends AID systems for youth with diabetes. Although it is unclear which diabetes type they infer, the recommendation likely pertains to those with type 1 diabetes. AACE strongly recommends predictive low glucose suspend and low glucose suspend systems for all patients with type 1 diabetes for the purpose of reducing hypoglycemia severity and duration or mitigating hypoglycemia respectively. ISPAD strongly recommends advanced SAP systems for pediatric patients with type 1 diabetes if an AID system is unavailable. For those receiving MDI who do not desire or cannot use an AID system, the ADA strongly recommends offering any insulin pump to adults and youth with type 1 diabetes and to those with other types of insulin deficient diabetes based on expert opinion. Specifically for adults and youth with type 2 diabetes who require MDI, the ADA strongly recommends insulin pump therapy as an option. AACE recommends an insulin pump with viewable only CGM data for all patients with diabetes when an AID system or advanced SAP system is unavailable or unable to be used. An insulin pump without CGM may be an option for patients with diabetes who have achieved glycemic targets with minimal time below range, experience infrequent symptomatic hypoglycemia, and regularly self-check blood glucose. Either MDI or insulin pump therapy is recommended by the ADA for pregnant women with type 1 diabetes. The ADA does not make a recommendation regarding the use of insulin pumps for gestational diabetes. Based on low-level evidence, the 2022 consensus on the use of AID technologies recommends considering AID systems as an option during pregnancy complicated with type 1 diabetes. No recommendation is provided regarding insulin pumps for gestational diabetes. According to the ADA and expert consensus, use of advanced technologies, including AID systems, can be considered in older adults with type 1 diabetes who have adequate cognitive function and ability to safely use such devices. Diabetes technology should be prescribed by well-trained healthcare providers who can use the device proficiently and oversee the application of these devices. Ideally, healthcare teams should be multidisciplinary and may include an endocrinologist or primary care provider and supportive staff. Initiation of insulin pump therapy may commence at diagnosis, especially for patients with type 1 diabetes. Considerations for starting pump therapy include evaluating caregiver patient readiness, patient desired pump type and settings, and appropriate education on potential device complications. Additionally, it's important for users and their caregivers to have realistic expectations of diabetes management when using an insulin delivery device. Selection of a particular device is personalized based on the patient's unique requirements, preferences, and proficiency. Notably, patients with type 2 diabetes may have barriers to starting or continuing insulin pump therapy, including limited insulin reservoir cartridge size of currently available insulin pumps and minimal evidence from randomized control trials evaluating insulin pump therapy in this patient population. To ensure appropriate and safe device use and to achieve maximal benefits, patients and caregivers should receive personalized structured education, training, and clinical and technical support at device initiation and on an ongoing basis. Education should ensure that patients are able to recognize the signs of a pump malfunction, be aware of whom to contact in case of such an event, and have a well-defined plan for emergency situations. It is also essential that patients have a firm understanding of basic diabetes management, even if they are using an AID system. Overall, discontinuation of pump therapy is uncommon, but may be attributed to cost or wearability issues, pump dissatisfaction, or suboptimal glycemic outcomes. Additionally, the occurrence of system-mandated exits, where users are required to revert to conventional pump settings due to the unavailability of automation, can ultimately lead to device discontinuation. Ultimately, the choice of discontinuing a device should be based on the user. Patients may be more hesitant to use an insulin pump, especially an AID system, if they are unable to use the device safely, prefer to control their insulin delivery, have concerns about whether the system is able to appropriately accommodate insulin delivery based on certain situations, or have concerns about alarm frequency. The iLet Bionic Pancreas and Vigo are the only reviewed insulin pumps that do not have contraindications for use. All other reviewed devices are contraindicated or labeled as a warning for the iLet Bionic Pancreas among people who are unwilling or unable to maintain contact with a healthcare provider or have inadequate vision or hearing to recognize pump signals or alarms. Additionally, most devices should not be used by patients who are unwilling or unable to self-monitor blood glucose as directed by their healthcare provider, and all insulin pumps should not be used near radiation or magnetic fields. Pumps that operate with the Dexcom G6 CGM sensor should not be used with hydroxyurea because this agent can falsely elevate sensor readings. However, this is a potential concern for all systems that are able to integrate with the CGM. Although not a listed contraindication, some user guides advise not to use the pump, including automated dosing technology during pregnancy, because the safety of the particular pump or technology has not been established in pregnant women. For the MiniMed 770G and 780G, user guides also note that there is a lack of data for use in patients with type 2 diabetes. All insulin pumps carry a risk of hypo or hyperglycemia and associated sequelae as a result of hardware or software failures and/or user error. Some insulin delivery failures can be attributed to an occluded insulin infusion set or presence of air bubbles in the tubing. In addition, all reviewed devices carry risk for skin irritation, infection, or other types of reactions at the infusion or CGM sensor sites. On rare occasions, it is possible for sensors or the cannula from an infusion set to break under the skin at the insertion site. Most insulin pumps contain small parts that pose as a strangulation or choking hazard to young children. I'll now review some of the considerations addressed in the report for developing potential prior authorization criteria. Please refer to page 35 of the report for additional considerations. For any insulin pump use, consider requiring patients to have type 1 diabetes or require intensive insulin therapy for other types of diabetes. For advanced SAP systems, consider requiring patients either have type 1 diabetes or have other types of diabetes requiring intensive insulin therapy. Patients with type 2 diabetes may also require experiencing hypoglycemia unawareness, severe or recurrent hypoglycemia, or significant glycemic variability. For AID systems, consider requiring patients have type 1 diabetes. May consider allowing off-label use of AID systems for patients with type 2 diabetes or other insulin-deficient diabetes on a case-by-case basis. Patients with other types of diabetes may be required by the payer to fail on-label systems first or allow the provider to express rationale for necessity of an AID system. May also consider restricting use based on the product-specific labeled age for approval and requiring prescriber attestation that the patient or caregiver is able to safely use the device, has adequate diabetes self-management skills, and has routine follow-up with their healthcare provider. Additionally, considerations include allowing providers to explain rationale as to why a particular pump is more suitable than others for their patient, given that many pump-specific usability factors could meaningfully impact whether a patient will successfully use a pump. May also consider allowing continuation of access to patients who are already using a particular insulin pump. In summary, insulin pump therapy is used in patients with types of insulin-deficient diabetes to imitate the natural insulin secretion by pancreatic beta cells and is an alternative to MDI. Insulin pumps are able to administer pre-programmed or adjustable rates of basal insulin and provide manual or automated prandial and or correctional bolus doses depending on the device. Notably, insulin pumps range in their maximal automation capabilities. Because there is a variety of insulin pumps available on the market, the choice of a pump is highly dependent on approved indications, patient-specific factors, and device features. Most of the reviewed insulin pumps have a general indication for use in patients with diabetes mellitus who require insulin therapy. AID systems are indicated for pediatric and adult patients with type 1 diabetes and have defined age restrictions. According to reviewed guidelines and a consensus statement, most patients with type 1 diabetes, including children and adults, are appropriate candidates for AID therapy. In addition, the consensus statement and ADA recommend prescribers consider offering AID systems to patients with type 2 diabetes or other types of insulin-deficient diabetes on intensive insulin therapy, but evidence in these populations is very limited. Thus, recommendations for AID use in populations other than type 1 diabetes are generally graded low to represent low-quality evidence or expert opinion. Thank you for your time and attention. Please let me know if you have any questions.
Thank you, Dr. Lula. Does the board have any question for Dr. Lula? So currently, the Utah Medicaid pharmacy is looking to move the insulin pump to cover under pharmacy benefit. It is right now covered under medical benefit, but we are planning to have it covered under pharmacy benefit, and there is not yet any prior authorization plan for that yet. One that is established, we will share that with the board for your expertise opinion. The next item on the agenda will be the Elevidys, but we do have several public comment related to this medication. First of all, that would be Dr. Butterfield from the ECHO Primary Children Outpatient. Dr. Russell Butterfield, if you please share your comment.
Sure. I'm Russ Butterfield. I'm a pediatric neurologist here at the University of Utah and Primary Children's Hospital. I direct the neuromuscular clinics, and our group takes care of most of the patients with Duchenne muscular dystrophy here in Utah and from the surrounding region. So pretty much every patient who might receive this medication is seen in our clinics. And I assume we'll go through a more formal review of all the data, but I wanted to speak in favor of getting this important medicine on the approved formulary, or whatever the right language is. I think it's an important therapy for our patients. It has a very narrow approval right now for age 4 and 5-year-old kids, but might be expected to expand as the studies mature down the road. We've been a part of the clinical trials doing these studies for a few years now, both with this gene therapy and then previously with the gene therapies for SMA and other Duchenne muscular dystrophy gene therapies. So we have some experience with the drug already. It's a, I think, useful drug. It's not as good as Zolgensma gene therapy for SMA that we've been using for a few years, but really an important step for some of our younger patients with DMD in providing treatment for them. I think I've seen the proposed criteria and for authorization. I think those look good. There is a couple of genetic exclusions on the label which didn't show up on that set of criteria, so probably need to be added. Those are things we're aware of in clinic and probably wouldn't be sending you someone who was excluded based on a genetic mutation anyway, but probably should be included there. I could send the details of that later. We do have real interest in safety with these genetic therapies, and there's been a number of different adverse events that were observed through the clinical trials and have been very much on the forefront of our thinking as we develop a plan to implement these treatments going forward. So we've put together, I think, a good safety plan and a good plan to educate patients and families on the drug and its efficacy and potential problems that arise with it, including very frequent follow-ups in the first, well, even the weeks prior to treatment, but especially in the 2 to 3 month time frame after delivery of the therapy. And that'll include pretty much weekly visits with us and laboratory testing to look for potential complications. Beyond that 2 to 3 months, we don't really see safety signals that are very interesting. We do have a long-term interest in monitoring for efficacy, and we have a really good group here of physical therapists who are part of the clinical trials as well, and can do the sort of more formal motor function assessments to follow efficacy over time. And that's data we've been collecting in SMA now since 2019, when that drug was approved for gene therapy, and we'll plan to continue to collect that now. So maybe that's sufficient. I don't know if I got it to my 3 minutes or whatever.
You're good, Dr. Butterfield. Anything else you would like to share with the board?
I think that's sufficient. It's just a really important drug for the DMD community, so we're excited to have it available for our patients.
Thank you very much for sharing that with us. The next public comment will be coming from Merritt Silverton of the Law Office of the Silverton and Parrott.
Good morning, members of the review board. My name is Marit Sievertson. My son, Brecken Kinney, is 9 years old and in 4th grade. 7 years ago, Brecken was diagnosed with Duchenne muscular dystrophy. It was not long after this diagnosis that my family quickly learned what this devastating disease meant for our son. It meant that my son would not leave my side when his brothers and friends played because he knew that he couldn't keep up. It meant that when we get together as a family, we'd have to hide our tears and look away from each other when we'd see Brecken struggle to walk up the stairs or even lift himself off the ground. It meant that we had to think about Brecken's future in terms of mobility, braces, wheelchairs, and whether he'd even have friends. Hope was a scary, dangerous thing to even think about. Having a child with this horrific disease meant that we couldn't let ourselves dream about the future because it was too painful. But now we aren't afraid to hope for his future. 3 years ago, Brecken received gene therapy as a participant in the clinical trial at Nationwide Children's Hospital. Today, Brecken isn't just climbing stairs and standing up with ease. He swims, he dives, he runs, he jumps. He is living the life that every sweet 9-year-old boy ought to be living. Our plans for his future don't revolve around worrying how we will help him get dressed, walk up the stairs, or even feed himself. Now, when Brecken talks about what he wants to do when he's older, my husband and I no longer force a smile. We smile because his dreams are a reality now. Just last night, we watched Brecken playing in a soccer game on his brother's team, running confidently up and down the field and passing the ball. A smile beaming across his face as he jumped into the air and high-fived his teammates after they scored a goal. These are the moments we thought we'd never see. We no longer just have hope. What we have is a therapy that can change the course of this disease. There are families in Utah who are waiting for their sons to share the same story of Brecken. Each one of you on the review board has the power to make this happen. And that is why I'm here today to ask what I want to ask you to do, to cover this gene therapy pursuant to the FDA label with as few barriers as possible and as quickly as possible, because time is muscle. This therapy doesn't repair what we've lost, but it does preserve what's still there. Please do not deny our boys in Utah this life-changing opportunity. Thank you.
Thank you. The next public comment is from Brian Denger from the Parent Project Muscular Dystrophy.
I just wanted
Thank you
to
very
thank
much.
you. I'm so sorry. I just wanted to say thank you so much, Mart, for sharing that story. It's very moving and powerful, and I hope you continue to share it. It's amazing.
Thank you very much. Happy to be here.
Thank you. I'll begin. I'll try to be brief. I've submitted written testimony, and my testimony basically amplifies the comments made by Dr. Butterfield and Merritt. I am a member of Parent Project Muscular Dystrophy, but also the father of a young man who is 29 who has Duchenne muscular dystrophy. Duchenne is a very complicated, progressive, degenerative, life-limiting muscle wasting disorder, and there are very few options in terms of modifying the outcomes in disease progression outside of glucocorticoid steroids. And most recently, within the past 7 years, we've had antisense oligonucleotides, exon skipping therapies that are a form of RNA manipulation that helps the body to produce a missing protein and preserve function in patients. Most recently, a gene therapy was approved by the FDA. And if you attended the public comments during the FDA meeting, you would have seen videos of these young children who were treated by this therapy, who were struggling at first. After treatment, they were able to undertake activities that were absent in their function. This doesn't happen in Duchenne. When a function is lost, it is gone. But for a therapy to allow a child to be able to climb stairs after struggling, to be able to run and getting both feet off the ground, that is remarkable. The committee hyper-focused on a functional measure, the North Star Ambulatory Assessment. It's a very blunt instrument and did not provide the same level of detail that was provided in the patient-reported outcomes. I am also here to ask that the committee support the draft proposal in terms of coverage that I have seen. Time is muscle, as Merritt had stated. My son is 29. He's been treated with with an exon skipping therapy. Again, it's a surrogate. It's a similar type of a product. It doesn't cure the condition, but provides a bridge for the missing protein and allows for the body to produce some of this protein and allow for muscle development and preservation. And he is 29. He drives a van with adaptation. He uses his computer. He uses his cell phone. The one issue that a lot of folks who are unfamiliar with Duchenne may not understand is that that increasing survival alone only lengthens burden. You have to allow for the improvement of ability. These young people are able to, with treatment, to help in dressing, to help in bathing. Yes, they may still lose the ability to walk, but then you have a motorized wheelchair that can be
That's time. Thank you.
Thank you for sharing your story with us, Brian. The next comment will be coming from Stephanie Kennedy from the Sabretta Therapeutic.
Hi, good morning. I just, since you published policy to label, I just want to thank you for this great policy and for giving these boys hope. And so with that, I would like to respectfully give back my time. Thank you.
Thank you for that. The next item will be the Ovides prior authorization will be shared by our team member, Stephanie Byrne.
Let me know when you can see it. Good morning, everyone.
We can see you, Steph.
Perfect. Like everyone said with public comment, these are pretty much all to label. First criterion is that the medication is prescribed by a physician who specializes in the treatment of DMD, which we anticipate will, if not all, for the most part, be Dr. Butterfield. Also, as he mentioned, right now the indication is limited to ambulatory patients between the ages of 4 and 5 years. They have to have the diagnosis of DMD, have a confirmed mutation in the DMD gene, and then, sorry, my cats are trying to say hi. I think some of the things that weren't in the first draft that Dr. Butterfield mentioned needed to be added are probably here, that the mutation must be contained between exons 18 and 58, and that the patient does not have a deletion in exon 8 and or exon 9 in the DMD gene. The next criterion is the anti-AAVrh74 total binding antibody titers are less than 1 to 400. This is the test showing that the patient does not have any immune antibodies to the vector that's delivering the gene therapy. It's not one that is FDA approved. However, in the healthcare provider treatment guidelines from Sarepta, they give instructions on using it and how to obtain it from the manufacturer. Next criterion is the member has not previously received Elevidys treatment, since it's supposed to be a once per lifetime treatment, as well as the next criterion, which is that the member will not receive exon skipping therapies for DMD together with Elevidys or after treatment, since the treatment is supposed to render these unnecessary. And then the final criterion is attestation from the provider showing that they're doing exactly what is recommended in the healthcare provider treatment guidelines, in making sure the patient has no infection, that they've assessed their liver function, and that they've assessed platelet count and troponin I levels. For authorization, it'll be 1 dose per lifetime. It'll be the 14 days from approval or until the patient reaches 6 years of age, whichever is sooner. And that can be addressed based on how treatment will be addressed at the clinical perspective.
Thank you, Steph. Is there any question, comment from the board regarding the criteria? Yes, Dr. Brinton?
I just want to say again, thank you so much for all the public comment. This has been such an amazing drug. I work with the Division of Complex Care, so we work with kids that have lots of needs for mobility or feeding or breathing, and I'm just so excited that these youth will have this option. And I'm hoping it sounds like the draft we have right now is meeting the recommendations from the specialists. Of course, I'd love to have it expanded to be able to help everybody have more strength as well over time.
Any others, question, comment from the board? Yes, Neil?
Question for Dr. Butterfield. Do you see this used in people or patients older than ages 4 through 5? Is there studies going on there?
There's studies going on there right now. There's a really pivotal study that we'll hopefully have a readout on first of the year. That study is a phase 3 trial, placebo-controlled. That is just finishing. In fact, we have 3 patients on that study, just finishing the first year, so that the placebo part this month. So we should have a good readout on that. That is kids 4 to 7 years old. So could expand that far. There's another study in planning stages that I don't think has started yet, at least at our site hasn't started yet in older kids. The treatment has been used on some of the earlier studies in kids up through teens, and I think even early 20s, but not in a sort of controlled setting. So I expect we'll see that. I also expect we'll see it going younger.
In those older kids too, with the same effectiveness?
I think probably not to the same extent that we're seeing in the younger kids. I think there's sort of a limit in efficacy that's based on how long you've had the symptoms.
Thank you.
Am I allowed to ask a question?
Yes, Dr. Butterfield.
I just had a question on the criteria mutation contained between exons 18 and 58. The label sort of specifically contraindicates any deletion in exon 8 or 9 based on risk for myositis, and then there's a sort of a warning on mutations in exons 1 to 17 or 59 to 71. So I think that exclusion is sort of addressing that bit of higher risk. And maybe just consider dropping that part. I'd probably agree with the 8 and 9, but the other part, maybe leave that to our sort of counseling with families. I think the risk is less outside of 8 and 9. And the reason for that, I think it's starting to come into focus a little bit after several patients with myositis across different DMD gene therapies has been seen. There's a more sort of a fetal form of dystrophin called utrophin that's very similar in structure, but it actually lacks exons 8 and 9, so you don't get the same type of tolerance from exons 8 and 9 that you might based on the parallel to the utrophin gene. So there's probably a biology there that's driving that. On the studies, they had a little broader exclusions that were that whole exon 1 to 17 kind of space. But I think they've kind of started to narrow that down based on some of the biology.
Thank you for that insight, Dr. Butterfield. We'll definitely take that into consideration. That's great.
Any other questions or comment from the board regarding the prior authorization criteria?
Yes, this is Dr. Weinstein. First of all, I want to thank everybody for their comments and for the work on this. Having done my pediatric neurology in the 1980s, it's really remarkable to know that we're able to offer real therapy and to see the consequences. It's remarkable, and I thank you all. Just pertaining to that last comment, then, do we want to consider a language change here for that 1, 2, 3, 4 for the bullet that I think it's the 5th bullet there where we say the mutation must be contained? Is Dr. Butterfield suggesting we make a language change there, that is not necessary to have that criterion spelled out? And if so, either eliminate that or change that language. Is there a recommendation to alter that in the PA? I'm not proposing it because I don't know exactly how that would be worded. It's a question. Thank you.
Thank you, Dr. Weinstein. Anyone on the board has a recommendation how to modify that, or we can, at the pharmacy team, we can take it back and reviewing the PI and consult Dr. Butterfield afterward and make the change to that criteria. At the moment, we can make the motion to pass the criteria with the note to modify or eliminate the bullet number 5.
I think I would move that if that's if I can get a second, and we can pass that off to the experts to work with the pharmacy team.
Thank you, Dr. Weinstein. And Stephanie Kennedy, you raised your hand. Yes.
Oh, yeah. I just wanted to just kind of clarify. So in the label, it's a contraindication if you have an exon deletion in exons 8 and or 9. But the 1 to 17 and 59 to 71 is just a warning and precaution. So as Dr. Butterfield stated, that's a conversation for the families and the physicians to have. So by that bullet having a mutation, again, this is a deletion. So, it's a warning and precaution. So I just wanted to clarify that in the label. It's a warning and precaution for the 1 to 17, 59 to 71. Thank you.
Thank you for that. So do we have okay. Yes, Dr. Keddington.
Yeah, I would second that motion, especially in addending anything that needed to be changed with the experts. Sorry.
Thank you. So we have a motion and a second. All in favor to approve the criteria with the either removal or change to the criteria number 5. Do we have all in favor?
Aye.
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 Thank you. Although opposed? All abstaining. So motion passed to approve the criteria as is with the removal or modification to criteria bullet number 5. Thank you very much. The next item on the agenda. Oh, yes, Steph.
Sorry, I didn't mean to raise my hand, but thank you,
Oh.
everyone.
The next item on the agenda will be the Roctavian, and we do have public comment from Rick Kegler from the BioMarin. Thank
morning
you
to
for attending, Dr. Butterfield. Sorry about that.
That's all right. Good morning to the board. My name is Rick Kegler. I'm a pharmacist and director payer and health outcome liaison for BioMarin. I want to thank the board for taking such quick action with Roctavian, the first gene therapy approved in the largest and longest running gene therapy trial for hemophilia A. Today, I will be available for questions and to offer some clinical outcomes which may not be readily available. Results from the year 3 data cut of GENERATE-1 trial showed that treatment with Roctavian among patients previously managed with factor VIII prophylaxis resulted in the following safety information from year 3. No new safety signals, no treatment-related SAEs, no participants developed inhibitors or thromboembolic events, and most common AE remained ALT elevation. Additionally, observed spontaneous bleeds were reduced from 2.3 bleeds per year to 0.5 bleeds per year. Observed joint bleeds were reduced from 3.1 bleeds per year to 0.6 bleeds per year. Median ABR is 0.3 bleeds per year compared to pre-treatment baseline of 3.3 bleeds per year, a 90% more than a 90% reduction. Mean factor VIII infusions decreased from 135 infusions per year to 8.3, a 94% reduction. 96.8% reduction in factor VIII usage. Participants with 0 bleeds in year 3 were 73%, and 92% of the patients remained off prophylaxis at the end of year 3. Results from the 6-year phase 1/2 Roctavian trial showed that treatment with Roctavian among patients previously managed with factor VIII prophylaxis resulted in a 95% reduction in treated bleeds at year 6, a mean ABR reduction over the entire study observation period of 0.8 bleeds, a 96% reduction in factor VIII usage, infusion rates, a 96% reduction in factor VIII usage, excuse me, I read that twice, 57% remained bleed-free compared to the baseline, and all participants in the 6E13 cohort remain off prophylaxis at year 6. I'll reinforce the importance of the availability of this important therapy, and again, thank the board and offer to answer any questions that there may be at this time.
Thank you, Rick. Any questions for Rick from the board? The next one will be a written comment from the Hemophilia Federation of America, and I will be sharing that. This is the Choi comment from the Utah Hemophilia Foundation, Hemophilia Federation of America, and National Bleeding Disorder Foundation. The Utah Hemophilia Foundation, Hemophilia Federation of America, and the National Bleeding Disorder Foundation submit the following public comments in response to HHS draft policy that would impose eligibility restriction on a gene therapy product for hemophilia A narrower than the label criteria recently approved by the U.S. Food and Drug Administration. Our nonprofit organization represents individuals impacted by the hemophilia and bleeding disorder across Utah and the United States. Our joint mission is to ensure that individuals affected by hemophilia and related bleeding disorder has timely access to quality medical care, therapies, and services regardless of financial circumstances, place of residence, or type of insurance coverage. Our organization do not recommend or endorse the efficacy, appropriateness, or sustainability of any specific products or treatment. We recognize further that the complexity involved in treating hemophilia and related bleeding disorder can result in very high medical expenses. We also understand that state Medicaid programs need to identify effective strategy to contain the costs. However, it's critical to a patient health and safety that such strategy do not compromise continuity of care for those with complex condition. We are therefore very concerned that the HHS draft prior authorization criteria for Roctavian up to the consideration by the DUR board at the September 14 public meeting exclude coverage for patients who have previously received Hemlibra. The proposed exclusion does not appear to have a clinical justification and is contrary to the existing standard of care as well as the FDA-approved label indication for Roctavian. As a result, the draft prioritization criteria would unduly restrict access to care for patients who are eligible for treatment with Roctavian. As a result, our organization urged the board to ensure all youth with bleeding disorder that are eligible to receive hemophilia gene therapy have full access to the product consistent with criteria approved by the FDA and the standard of care recommended by NPDF, Medical and Scientific Advisory Council. MASAC have noted that limited access using restrictive drug formulary, such as those requiring prior authorization, PDL, and failed first-step therapy, negatively impacts patient care and can ultimately result in higher drug spending. Therefore, drug benefit design employ these methods should be avoided, and the choice of product used by an individual should remain a decision between patient and physician. If you would like additional information,
That's time, Noon.
Thank you, Brian. With that comment, the next item on the agenda will be the Roctavian PA. This is the draft prioritization criteria for Roctavian. This criteria is first is prescribed by hematologists specialized in the care of patients with hemophilia A. The patient is 18 years of age or older. The patient has not received Roctavian or any other gene therapy before because this is supposed to be a one lifetime dose. The patient has diagnosis of severe hemophilia defined by congenital factor A deficiency with factor A activity less than 1. Patient does not have antibody to adeno-associated virus serotype as detected by the FDA-approved test. Currently, there is only one test on the market that is FDA-approved, and this is manufactured by ARUP. Patient have no previous documented history of detectable factor A inhibitor. Patient has been on prophylaxis factor A for at least 1 year and has at least one serious bleeding event while on prophylactic factor A. And then prescriber attests to these following assessment prior to the administer of Roctavian: obtaining and evaluating liver function tests, assessing the patient's ability to receive corticosteroid and other immunosuppressive therapy that may be required for an extended period, that the patient does not have an active infection, either acute or uncontrolled chronic infection, that the patient does not have any known significant hepatic fibrosis or cirrhosis or mannitol hypersensitivity. And we authorize only one dose per lifetime for this medication. To note to the previous public comment on the hemophilia, exclude the patient has been on Hemlibra, we have removed that criteria from the draft PA. Does the board have any question, comment to this PA? Of note, this PA has been sent to the HTC Center for their feedback. And with some change from today, we will also send it back to the HTC for their comment as well. If there's no comment, can I have a motion?
I'll move to approve it with the amendment that's already been made.
Thank you, Dr. Turner. Do I have a second?
Second.
And all in favor?
Aye.
Aye.
Thank you. Ondo oppose? Okay, all abstaining. So the motion passed for this PA criteria. With that, that is all of the item on today's meeting. The next meeting will be on October 12th, and we will review sickle cell disease, the second part of the sickle cell disease. Okay, do we have a motion to adjourn? To end the meeting.
Noon, I'll move
Move
we
adjourn.
Or I'll second Dr. Weinstein.
Thank you.
There we go.
Thank you.
That'll work.
All in favor?
Aye.
Odo, okay. Odo oppose, all abstaining. Thank you very much for attending the DUR meeting today. See you all next month.
Thanks, everybody.
Thanks, everyone.
Thank you.
Bye-bye.
Thank you.
Have a nice day.